Going to discuss about the use of excimer laser in high thrombus burden. So excimer laser was actually developed in 1990s with an aim to modify the atherosclerotic plaque as an alternative to the plain balloon angioplasty, which caused a lot of dissections and flow-limiting dissections and restenosis. But however, down the line, with initial unfavorable results, advent of stent, expensive cost of the catheter, and no refinements in the development of catheters, its use became limited. Later on now, with better understanding of the technologies, refinement in the equipment, and the catheter technology, there has been a renewed interest in use of excimer laser for its best use in specific circumstances, more rather than not as an alternative, but as an adjunct to the PTCA. So what excimer laser is? Let's understand the science. Xenon molecule and a very diluted hydrogen chloride in a laser medium, when high voltage is added, they combine into a dimer, which is xenon chloride. And whenever this excitation is removed, it releases a photon. This photon generated is in the ultraviolet range of 308 nanometers. It excites the electron and produces two photons of the same length and phase. And there are a lot of mirrors inside which amplify this process, resulting in a formation of the laser beam. And this laser beam actually break the covalent bonds inside the molecule. And unlike the infrared ray, it has a less penetration into the tissues and absorbed only for less than 100 microns length, and thereby causing less of collateral damage. The duration of these pulses are nearly about 125 to 200 nanoseconds, and the output is about 30 to 80 millijoules, with the repetition of varying according to the specification that you want, from 25 to 80 pulses per second. And this is the way it works. In this 200 nanoseconds, there are photoablations followed by a period of rest, where in this animated cartoon, you can see here the laser beam emitted causes the breaking of the bonds, which is called the photochemical pathway, and thereby generating some thermal energy and a kinetic energy, which actually finally breaks down all these particles into pieces which is less than 10 microns, which can be then absorbed by the system. So use of laser actually follows the principle of 5S, where we need to select our patients. We need to size the catheter, which should be less than 2/3 of the vessel diameter. We need to adjust the settings. We call it fluence and frequency. Fluence is the pressure with which you are hammering, and the frequency is how frequently you are delivering these energies. And then, most importantly, we need to use a saline flush, keep the system clear of the contrast, because contrast can actually resulting in high pressure energy delivery. And very importantly, we should advance the catheter very slowly. So this is the various catheter size. Most commonly, we use a 0.9 and 1.4 catheter in the coronary, which are respectively 5 French and 7 French compatible. So these are the various indications. Mostly it is used in order of frequency and the relevance in balloon uncrossable lesion, underexpanded stents, diffuse instant restenosis, aortosteal lesion, moderately calcified lesions, large intracoronary or intragraft thrombus, and finally the saphenous vein grafts. And today, I've been told to focus on the large intracoronary thrombus or intragraft thrombus. Now, what is the problem with large thrombus? It actually causes, if we look at in the STEMI situations, procedural complications with distal embolization, no reflow, microvascular dysfunctions, and hence greater myocardial damage. If we can reduce it, it improves the outcome. However, our attempts to do that with routine thrombectomy, routine manual aspiration has of an uncertain value, hasn't shown to be of any clinical benefit in most of the trials. On the other hand, the excimer laser, this directly targets and vaporizes the thrombus, has been found to be safe, effective as an adjunct therapy. And this photoablative mechanism of thrombus vaporizing may exceed the simple mechanical effect what we do with the thrombectomy devices. So let me take you to one case. This is a 45-year-old gentleman who presented with anterior STEMI. He had a prior intervention in 2019, but details were not known. Risk factors, he's a smoker, no other risk factors. So his bedside echo in the emergency room showed moderate LV dysfunction with akinetic LED territory. So he was wheeled into the cath lab for a primary PCI. And if you look here, the LED ostia was totally occluded. So what I did, I just passed the wire, and because there was a stent inside, and I did not know exact location of the stent, although it was looking to be an osteoproximal from the cardiac sellout in the angiography. So did a quick run of an angiography. For the interest of time, I'll just run through. What you can see here is a highly thrombotic burden inside the stent. Not sure whether there was an intraplaque rupture or not. So just took a 0.9 millimeter excimer laser, passed it, and one run, and you can see in the middle how clear is this with normal TIMI flow, absolutely pristinely clear. However, there was some narrowing at the bifurcation. I used, and the ostia, I used a plaque modifying device in the form of Wolverine 3.10, 3.0 into 10 at both locations, and then used the stent to cover it up. And this was his final views. Absolutely revascularized artery with good perfusion. And these were in final, the pictures in the IVUS. You can see here the stent was very well expanded and absolutely pristinely clear of any thrombus residue. And these were the angiographic final images. So do we have data on this? Most of the data on laser dates back to 90s and early 2000s, before 2005 and 6. So let's look at here. There's a couple of studies. These are older studies. The Caramel multicenter trial, which again showed use of laser causing increase in TIMI flow, more gain in the MLD, and actually this decreased the target stenosis. This was another laser AMI trial, again older trial, published in 2007, where they found that the diameter stenosis decreased, TIMI flow increased. There was more of, however, the post-procedural myocardial blush and the final corrected TIMI frame count did not differ, but it was found to be safe and feasible. Recent studies, if you look at, again, this was a study from the Korean group. This was a laser vaporization of the thrombus. What was found that the baseline thrombolysis, if you look at, the myocardial flow grade was better, and ELCA effectively vaporized the intracoronary thrombus in STEMI patients, even after the use of thrombectomy devices. Again, further studies, it showed that the myocardial deviation enzyme and potential improvement of the systolic functions compared to the manual aspiration of the thrombus in patients of STEMI with use of laser. Very recent studies, again, it improved the myocardial infarction, if you look at the myocardial, the blush grade, and reduced the intraoperative slow flow or no flow phenomena in patients with STEMI, even who presented late, actually 12 to 72 hours after the onset of pain. It has been used in very few cases in acute MI situations with subtotal blocks, and all of these patients had a cardiogenic shock where it has been successfully used, but this is a very small number in single digits. What complications can occur in excimer laser? There can be sometimes major dissections, abrupt vessel closure and perforations, but with proper techniques and appropriate patient selections, and this can be reduced. So to conclude, in STEMI, ELCA is feasible, safe, and effective. It causes aggressive thrombus removal. And after the thrombus removal, we can better understand the morphology of the culprit vessels and decide on our therapeutic strategies. Once we remove the thrombus, we can always look at the geographical miss, because many times the pathological culprit lesion may not be at the site of the severely stenotic lesions. Distal embolization can happen during the insertion of the catheter, but it's usually very infrequent. Thank you.
Thank you, Dr. Sanjeed, for this also timely and very interesting relation. We have just one question, because we have the time for one single question. Okay, I will go for the question. We don't have so much laser in Europe so far. So which is the learning curve that you would suggest for a center that is starting his experience with this device?
Well, one is the patient selections you have to look at, and most often, if I look at this acute MI, is not the primary subset that we look for. But if I stick to his primary STEMI group, early wiring and use of 0.9 catheter as fast as possible. But most importantly, we should advance the catheter very, very slowly, because that slow movement gives you a wider lumen and more lysis of the thrombus. in acute MI settings. Otherwise, we usually look at the standard protocols and work on it.
And what is the contraindication? I couldn't see that. Contraindications for the use of ELCA.
If you have an acute bend, if you have a small vessel size, those are the contraindication standard that we should not use it, because those are the settings where you will likely end up with perforation.
Okay, thank you.
Thank you.